All right. So let me just go kind of straight to the course objectives, since this is going to be for continuing education hours. Those of you that need them, these are some of the things we're going to discuss. And at the end of it, you should be able to kind of tell a little bit of the history of hospice. It's very interesting. Discuss about 3 components of the hospice philosophy, list 4 members of the hospice team, summarize 5 of the myths of hospice, and there's lots of myths of hospice. We're going to try to hit on every one of them. And then identify 5 different types of terminal illnesses that qualify for hospice care. And there's a lot of those also. So it's interesting, the history of hospice. And I always like starting with this because most people have no idea where this came from or the length of time that we've actually had the service in the United States. So the word hospice, as you see there, is Latin, and it actually means guest or host or guest. So that second bullet point there, travel-weary crusaders on their way to the Holy Land found places of refuge in the monasteries, and those started to be known as a hospice because so many of the people there were in ill health and they spent their last days there. So originally the word hospice was just to be a guest or to host someone, and so many people were spending their last days there that they started calling the place the hospice. And then coming to this country in 1963, Cicely Saunders was in the process of establishing a hospice in London, and she visited Yale University. She lectured about holistic hospice because that's what hospice is. It is holistic care, which in the 1960s, that wasn't really something we were talking about yet at that time. And she lectured to medical students, nurses, social workers, and to chaplains. And this kind of set off a chain of events. So she came in 1965. In 1968, the dean of the Yale School of Nursing took a sabbatical to go work there at St. Christopher's and learned everything that she could about hospice. Now, in the meantime, in 1969, many of you have heard of Elizabeth Kubler-Ross, and she came out with her booklet called On Death and Dying, where she talked about the 5 stages through which terminally ill patients progress through. And it became an international bestseller. We still use it today. We now realize that, and she realized before she passed away, that not only and we don't even call them stages anymore because we know that we don't necessarily do stages of grief, but that those of us who are taking care of people who are dying also go through each of these emotions and feelings that she talked about. But the point was that she brought it to the forefront and she got people to talking about death and dying, and we hadn't been talking about it before then. So in 68, we've got the dean of the Yale School of Nursing going over to London to learn about how they were doing hospice there. In 69, Kubler-Ross comes out with this book. And then in 72, so a couple of years later, Elizabeth Kubler-Ross actually testified at the first national hearings on the subject of death with dignity, the way they worded it, death with dignity. And it was a US Senate Special Committee on Aging. And she said something in that talk that I really think stands out. And I put it in red on here. She was basically giving a testimony about death and dying. And she said, "We live in a very particular death-denying society. We isolate both the dying and the old, and it serves a purpose. They are reminders of our own mortality." That was in 1972. And I think about that still today, and I can see aspects of that in some places still today. So in 1974 then, they opened the first hospice in the United States, and it was opened in Connecticut. Also in 1974, the first hospice legislation was introduced to asking for federal funds to help support hospice, and it was denied. 1974, it was denied. So it was private pay in the 1970s, if anybody had hospice. Then in 1982, it was reintroduced to Congress, and they included a provision in the Medicare Act, Medicare hospice benefit, and it was called a sunset provision, where it was kind of like, we're going to try it from 1982 to 1986. We're going to see. So Medicare did start having a Medicare benefit, and then in 86, they did make it permanent, and it's called the Medicare hospice benefit. And so many people do not realize that hospice is part of Medicare. It is a Medicare benefit. Then in 1991, hospice care was authorized in military hospitals and became part of the VA benefit package as well. And then this is the most recent data that I could find. We usually do run about a year behind on numbers and statistics when they come out, and I've got all of these in August of this last year, but they're 2019 numbers, and I got them from the National Hospice and Care Organization. So today, in 2019, now keeping in mind, and especially the older I get, the 1970s weren't that long ago. It just wasn't that long ago that we weren't even using the word hospice, and we didn't have the Medicare benefit. That was in the 80s. And now there's over 4,300 hospice agencies in the United States. About 55% of them are for-profit, which means that the others are not for-profit. And as in 2019, there were 1.49 million patients in the United States that were on hospice. So just to give a background on where did hospice come from. So the hospice philosophy, even today, I talk to an awful lot of people that whenever you say the word hospice, it almost is like fear just enters their eyes. And as I talk to them, sometimes it's because they may have had a bad experience years and years ago at the end of someone's life, or they have started using the word hospice to mean they're dying right now. They believe that when they hear that word hospice, it means that they're imminent. And as we're going to talk about, hospice does not mean that they're imminent. Hospice means that we think they've got less than 6 months. But you can be on hospice. I have known people that were on hospice for 2 and 3 years. Every time it was time to recertify, if they could still show, progression in the disease, they would recertify, or they would come off of hospice and then go back onto hospice. That's something that can happen too. And so just kind of breaking through some of the myths and the misunderstandings about hospice is a lot of what we want to do. So hospice, the good thing is that from the 1960s, whenever Saunders did come over from London and introduce it as a holistic program, it has stayed that way. It's a holistic approach, and it is the physical, the emotional, and the spiritual concerns that it's not just of the patient, it's about the whole family. A good hospice takes care of the entire family, not just the person who is dying. The care also is to be individualized so that it meets all the needs of the patient and the family, which means that hospice is not cookie cutter at all, should not be cookie cutter. And it also is responsive to differences in lifestyles. This is more of the hospice philosophy. Hospice affirms life. Because I have, over the years, I've heard people say things like, well, that's just whenever you're ready to give up. That's when people go on hospice. And that's not the case at all. Hospice is about living. Hospice is about quality of life and dignity and independence for as long as we can have it. I see Wilson shaking his head. He knows that's the truth. Big hospice supporter. It promotes self-determination as patients and families participate in their plan of care. Lots of education is provided by the hospice team, and hospice is a big team, and we're going to talk about those team members. And then it also promotes the understanding and the accepting of the journey of life eventually leading to death, and it encourages people to view this experience as an opportunity for growth. And it actually enables the family and the person who is passing to go through, and it helps them with their life review. It helps the family kind of with a life review of that person. You can do legacy work during this time while you're on hospice. And those of you who work in hospice, you know exactly what I'm talking about. I have helped people sit down and write out stories and books and make recordings and things that they can leave their families. It can be a really, really good time. And then it emphasizes, and I went ahead and just put here in dark, because we hear hospice and palliative care, and people will say, okay, what's the difference in hospice and palliative care? So the palliative part of it is to make a disease or its symptoms less severe without removing the cause. So a person can be on palliative care and still be receiving treatment to hopefully cure whatever they have going on with them. When you're on hospice care, you're not receiving treatment for a cure. And we'll deep dive into that more in just a little bit. But many places are called a palliative and hospice company because so many folks will go from being on palliative care into being on hospice care. And again, we'll talk more about that. So why choose hospice and when to choose hospice? And this is the main thing, is this first bullet point. If you can see the screen, when medical treatments have been exhausted or the burden of treatment outweighs the benefits, it may be time to consider hospice. So an example might be someone, and this is a personal story of someone in my own life who had done cancer treatments for years and would get better, and it came back and would get a little bit better. And it got to the point that she was homebound. She was able to say that she felt like all she was alive. She didn't feel like she had quality of life. She felt like she was living to go to doctor's appointments and living to do treatments. And she was able to make up her mind to call in her family and say, I'm not doing the treatments anymore. And when she stopped her treatments, she actually kind of rebounded. Like we'll see a lot of times when somebody stops a chemo or radiation, and they actually had about 4 really good weeks together right there. And she decided to go on hospice and to stop treatments. She switched from doing palliative care over to doing hospice care. But that's where when the treatment outweighs the benefits. And that's a personal decision that families and that people have to make. That second bullet point, most people would like to end their lives surrounded by families and friends. And so by bringing hospice either into the home or bringing hospice into a care center, because hospice can go anywhere, people are able to do that. Most folks, whenever they look at, when we have that choice of end of life, what do we want it to look like? And we look at what does life support look like in the hospital. And then we look at somebody being able to die with their family and loved ones around them, with music playing and a diffuser going, and we can just create this sacred space. Is very different from being in the hospital hooked up to tubes and wires and not being able to touch them. And so it's being able to have a little bit more control. And that's what that next one is, a greater sense of control for patients and their families. So, and hospice will go into nursing homes. There's hospice centers. You can have hospice anywhere. And the hospice experience can foster spiritual and personal growth as the hospice team empowers patients and families to manage difficult situations. It's so powerful. If you've ever had anybody on hospice and had a really good hospice team walking you through that. So the structure of hospice, it is made up by an interdisciplinary team, and I just want to go over this real quick because I really want to get to the myths. But the team is the medical director, which certifies the patients as eligible. They give direction and support, they write orders, and they can visit the patients as needed. So there's a medical director to the hospice. And then there is a director of patient care services. They manage the team of providers. They supervise the patient care staff. They make sure that there's a plan of care, or sometimes you hear that called a care plan. Then there's a nurse case manager who manages all of the care that's provided by the LVNs, the CNAs. So the LVNs, the nurses, the CNAs, or the nursing assistants, and coordinates with the social worker, that SW is social worker. And then you'll hear HHAS, the home health aides, and they are to help with ADLs, which are activities of daily living. They provide companionship. They sometimes do light housekeeping and will assist with meals if they're coming into your home. Even if your loved one is placed in a facility, you still get a home health aide who can go in and assist with bath time and ADLs. ADLs are just their grooming, brushing their teeth, assisting with mealtime, toileting type things. And then there's a social worker, and some places have a counselor on staff that is emotional and mental support and counseling. They do a lot of education, financial evaluation. They can assist in finding resources. They organize transfers if somebody's in the hospital and then they're going home, or if somebody's at home and they're going to a facility. They help with admissions. They provide transportation. The social worker wears many, many hats. Those of you who are on and are social workers, you know that. Then there is a spiritual care coordinator. Some places they will just call this their chaplain, that helps with emotional and spiritual support. They will do religious services. They normally are non-denominational. They're there for prayer support. They can assist in the funeral. They can assist in planning with memorials. There's also a bereavement coordinator, and this is the person who follows up with the families after the patient's death. And usually it's about 13 months. I need to change that. It says 12 months after the death. Most places keep you on service for 13 months, and that's to get you through that first year plus a month, because that anniversary of the death, that first anniversary of the death, can be very difficult. And then hospice also has volunteers. And there are volunteers that can actually come and sit bedside when somebody's imminent. And in lots of places, that's called an 11th hour team, where they will stay with the family and stay with the person who's passing. They can provide companionship. I used to be a hospice volunteer many, many years ago. That's one of the ways I got started in this. And one of the things I was asked to do the most was to sit and read the Bible to people, where they wanted somebody to read the Bible. They couldn't do it any longer. The family needed a couple of hours in the afternoon, and I would go and just sit and read with them and just be with them. So providing that companionship, and then assisting with any type of support or projects. So here's some things that hospice helps with. And the main thing, symptom control and pain management, making sure that they are kept as comfortable as possible. Hospice has ways of helping with pain management that lots of times the regular layperson had no idea. What do you mean there's meds that can go under the tongue, or there's a pain patch, or there's this little, the patch that goes behind the ear. There's so many different things that hospice can do to help with pain management and symptom control, so that a person is not uncomfortable during the last part of their life. They also really help with skin breakdown. When somebody is starting to get closer to the end of their life, and maybe they're not moving as much, or in the case of dementia, as the brain just isn't working like it normally would, and it's not metabolizing foods, it's not metabolizing meds like it would, you can start to get some skin breakdown. And so they'll help with skin breakdown. Nutritional counseling, making sure that they're getting in as many calories as they can, high protein, that type thing, and can assist the family with what kind of foods they should be eating, and talking with the family about allowing them to eat the foods that they want to eat at this particular time, because that becomes very important too. They help with ADLs, the activities of daily living. They can step in and be mediators for social and family problems. That's something that lots of social workers and chaplains work with the families on family issues that might be going on during the time. They help with the companionship, the volunteers, spiritual and emotional needs. And then if advanced directives, BNRs, do not resuscitate, power of attorneys have not already been put in place, the social workers with hospice can help with that as well. More things they help with: if somebody is at home, hospice can go through your entire home before your loved one even gets home. If they've been in the hospital and they're coming home to be on hospice, they can help with safety issues, community resources. They focus on quality of life, and they are available 24 hours a day. That's one of the myths we're going to talk about, is just because somebody goes on hospice doesn't mean that somebody's going to come sit bedside with them 24 hours a day. That's not going to happen. But they are available 24 hours a day. You can get a hold of somebody who can help you 24 hours a day. All right, hospice myths. We're going to get started on some of these. So, and these are things, the reason they're on this program is because I've either had it said to me, or it's been asked, or it's one of these. So if some of them you think, oh my gosh, these are real things that come up. If a patient lives longer than 6 months, he or she will automatically be discharged from hospice. And like I said earlier, you can be on hospice. There is not a time limit for how long you can be on hospice. But many people live longer than the 6 months and remain on hospice. Medicare regulations give unlimited 60-day recertification periods. So we will also be sending you, when we send you your slides, I could not get this to load on these slides because I am still learning all of this. I've got a paper called Hospice Eligibility Criteria, and I will have Jamie include that with these slides where you can actually look and see what it takes to qualify for hospice for different diseases that we'll talk about at the end. And you'll be able to see yourself and how they stay on hospice. Hospice is only for dying people. We kind of talked about that earlier too. Hospice is for the entire family. It's a family-centered concept of care, and it focuses on the grieving family as well as the patient. If a physician orders hospice for a patient who lives longer than 6 months, the physician will be in trouble for fraud. No, they won't, because the physician does their best to be able to say that we believe they're at the point where they only have 6 months left, but there's no way that they could possibly know that. So all they're stating when they give a patient a prognosis of 6 months or less is that if the patient's disease progresses as expected, then they will live less than 6 months. But again, when we're talking about something like dementia, we know that people can progress and then plateau, and they can ride that plateau and stay there for a good long while, and then they'll progress again. Patients on hospice can no longer go see their doctor. You get asked this a lot. So hospice encourages patients to continue to see their regular physicians. If it comes to a point where the patient can no longer get to the physician's office, the hospice nurse keeps the physician updated. So you can still see your doctor while you are on hospice. And this one I put on a slide all by itself because this is the one that I really wanted to focus on. I've already talked about it a little bit. If patients go on hospice, they can no longer seek any treatments, and that is not the case. Symptom management and pain control are the main goals of hospice treatment. There are many treatments that are for comfort care. Only curative treatments cannot be sought. So, for example, if somebody is on dialysis, depending on what their disease is, depending on the reason they're on dialysis, dialysis might actually be a comfort measure. So they could continue with some dialysis or with their dialysis. It may not. It depends on what, that's why all of this is it's individualized. It's only curative treatments that you don't do while you're on hospice, but you absolutely can still do treatments. Treatments that provide comfort. Hospice is only for people who can accept death. Hospice is for the living, And many patients and families have not made a decision to accept death whenever they first come on hospice. That's why you've got this interdisciplinary team to walk you through and talk you through this. But hospice is not, does not have a magic wand. That's why I put that on there. Hospice professionals are trained to help people move at their own speed toward making these decisions. Hospice is for people who don't need a high level of medical care. That's not true at all. Hospice is very serious medicine. The medicine of end of life is very serious. Most hospices are Medicare certified, and that requires that they employ experienced medical and nursing personnel with skills in symptom control. It is a specialty. This isn't just something that, first of all, the field itself is not something that just anybody can work in, because it's a very difficult field to work in. But symptom control while using comfort, not using needles as much, not using the IVs, not providing discomfort while trying to take away the pain. So it is definitely serious medicine. Hospices offer state-of-the-art palliative care using advanced technologies to prevent or alleviate distressing symptoms. Here's another myth. Hospice is for when there is no hope in sight. So when somebody is terminal, when somebody has been told that death is in sight, we've got two options. We can either yield to hopelessness and just throw our hands up, or we can choose to live life as fully as possible until the end. And that's what hospice is about. And I see it as a gift. And many people see that the gift of hospice is its capacity to help families see how much can be shared at end of life through personal and spiritual connection and through sharing. Hospice care is expensive. And we talked about earlier, it is a Medicare benefit. So most people who are over the age of 65 are entitled to the Medicare hospice benefit, but we also know that people go on hospice that aren't 65 yet. So what happens then? A lot of insurance will cover hospice. And it says here many younger patients have private insurance which covers hospice, and it's far less expensive than the alternative hospital or nursing home care. But most hospice also does a number of pro bono cases, especially the nonprofits where they give back. So they will take on a certain number of patients that they aren't charging. And then the most frequently asked questions about hospice. And some of these we've covered, but I really want to be able to answer any questions or to deep dive into particular ones or anything that you may have had happen. So people will say, well, what is it that they even do? What is it that hospice does? And like I said, they come in and they provide an individualized service, and it's not just about that comfort care of the person who's passing, but the symptom management, the emotional support, not only for the person who's passing, but for the entire family. The spiritual support is brought in, the psychosocial intervention. They address issues most important to the patient's needs and wants at the end of their life, focusing on improving the individual's quality of life. Many different hospices will do almost like a make-a-wish, or if you let your social worker know what it is that you're wanting to do, or that your loved one's wanting to do that they never got to do, or that they're wanting to do one more time, a lot of times that's where they will involve the volunteers. I had a woman who had never gone to a Texas Rangers game. That was her wish, was to go to a game and watch the Rangers play, and they arranged for her to go. And I was able to go with them and take her and her grandson, and they were able to get it donated. They got to sit in a suite and to go to a Rangers game. I had somebody who wanted to spend a weekend at the Gaylord Texan. That was their wish. That's what they wanted to do. They had heard it was beautiful and wonderful, and we were able to arrange that. So it can be anything from something like that. I had somebody who wanted to go to the Ripley's Believe It or Not and the Wax Museum in Grand Prairie. That was one of the things they wanted to do. They'd never been. And we were able to do that through hospice. Hospice arranged for that to happen, for the family to go. And most places do donate that stuff. I think all of the ones that I ever took anybody to, we ended up getting it donated. But people don't stop to think about that hospice helped with something like that. And they did, because they're talking about that end of life and making those memories. Many of these that I helped with involved grandkids and getting to go and make those memories and take a lot of photos, that type of thing. How do I know when it's time for end of life care? Patients are eligible for hospice when they have been diagnosed with a terminal illness with a prognosis of 6 months or less. At that time, comfort care and symptom management become the primary focus, and curative treatment is no longer the patient's choice or option. So let's talk specific to something like dementia. We know that all of the dementias are terminal. We can honestly say that anybody who has dementia basically is kind of on palliative care anyway, because there's nothing curative for dementia. We don't have any treatments. The memory meds are symptom meds. We know that. We're treating symptoms. We're doing palliative care with people with dementia. This is why we start talking hospice really early, because the sooner that somebody can get on hospice and it be a Medicare benefit and you get this added layer of support, and this is what I have always called hospice, it's this additional layer of support for the family and for the patient. When you get a social worker and a chaplain and another nurse and another CNA, and that's part of a Medicare benefit, you're not having to be out of pocket for this. And so many times people get on hospice and then will say, I wonder if we would have qualified sooner. I can't believe I didn't get. So not being afraid of it. A family can ask for a hospice evaluation. The worst thing that they're going to say is that they don't qualify yet. And they'll come back and they may evaluate them again in another month or two, or after an event happens. And again, those will be on this hospice eligibility criteria that I'm going to send out, where you can see specifics of how somebody does qualify for hospice. And then when should hospice be called? Hospice should be called at any time the patient's been diagnosed with a life-limiting illness. It is appropriate to discuss all of the patient's care options, including hospice. At another place that I used to work, I used to talk about hospice at move-in, whenever people would move in, because it was where we were eventually headed, just to start using the word so that people wouldn't be afraid of the word, because we are dealing with a terminal illness. And so they can do a hospice evaluation, and like I said earlier also, they can go on and off of hospice. They may be on hospice and hit that plateau, and they usually will use the word graduate. They will graduate off of hospice because they've hit a plateau, or they may even get a little bit better depending on what they go on hospice for. And that's okay. They can come off of hospice and then they can go right back on hospice. I've had people go back on hospice within 2 weeks because they had a fall. They got pneumonia. They developed a UTI. They started to lose weight. All different kinds of things that showed progression in their disease, and then they qualified for hospice again. I had a gentleman that comes to mind who was on hospice for 3 years. Every time he would be riding a plateau, he'd be doing great, and it would come time for him to recertify, and his wife would come by my office every time and say, something will happen this week, you watch. He's going to lose a couple of pounds, he's going to have a fall, he's going to choke, he's going to get a UTI, because he knows it's time to recertify. And of course she was joking about that, but he'd recertify every time. Where is hospice provided? And we've talked about hospice can be in the home if somebody chooses to have hospice come into their home. It's the setting that best meets the needs for the family. The most common setting is at home. Hospice care is also provided in nursing homes. It's provided in assisted livings. It's provided in ILs. It's provided in hospital. My grandmother died in a hospital hospice wing, where they had a wing that was just for hospice patients. It's all according to the patient care needs. And are all hospices the same? No, they are not. So some are for-profit, some are not for-profit. They all have the same general philosophy. They should all have that same team. They should all, again, if you go back to that philosophy, we had 2 slides of what is hospice supposed to be about. They should all follow that, but they're not all the same, just like all nursing homes aren't the same. All assisted livings aren't the same. So you do want to shop around. You want to do word of mouth. You want to talk to other folks. And then you want to interview the hospice teams. Can my pain and symptoms be controlled at home? Most of the time, yes. Pain and symptoms can be controlled at home. If a symptom becomes a problem, the hospice nurse can be reached 24 hours a day, 7 days a week. And most symptoms can also be controlled without injections and without IVs. Hospice medical directors are always available to adjust medications. So then people will say, well, then why couldn't I be at home if I'm on hospice? And again, it depends on why the person is on hospice. If somebody is on hospice and they have dementia, it may be that they're also having other symptoms of dementia with some behaviors, and that's the reason why they can't be at home. You're actually placing them because of the symptoms of the disease, not necessarily because of the hospice. And some people just don't want to be at home. They don't want to die at home, or the family doesn't necessarily want them dying in the home. Again, it's a personal decision. Does hospice provide 24-hour in-home care? And they do not. Let me go through this and we'll talk a little bit more about this. Hospice provides intermittent nursing visits to assess, monitor, and treat symptoms, as well as teach family and caregivers the skills they need to care for the patient. Team members are available 24/7 to answer questions or to visit anytime the need for support arises. So as we go through the journey of the disease, you start getting more and more visits. So the nurse may come more often, the aide may come more often, the social worker, the chaplain may come. They may start out coming, I'm going to say every other week, and then they're coming once a week, but they're calling you twice a week. And when they become imminent, you may see them every day. Now, we used to be able, this changed several years ago, when somebody became imminent and they were actively passing, we used to be able to have a nurse sit bedside, and they would call it a crisis care nurse or critical care nurse, and they could sit bedside. But all of that changed several years ago, and you still can have that, but you can only have it if their agitation or pain is uncontrolled. Then you can have the nurse sitting bedside to continue to give them medication. So normally we do not have a nurse sitting bedside. They come in, they adjust the meds, and then they leave, and then they come back. But they're available. And if you're in a facility, lots of times they are still around because they may be off seeing other patients, and so they can come back in and check on you whenever you are at the end of someone's life and you're sitting bedside. So when somebody, like I said, does go on hospice, that does not mean that they're imminent. Lots of people go on hospice that you're sitting next to at church or that you're seeing in the grocery store. They're on hospice. They just have a terminal illness. So when I talk about when somebody is imminent, that's whenever we're down to those last few days. And most of the time it is 2 to 3 days. I've had people go 4 to 5 days of when they are actively dying. This is the time that the family gets to come in, and we call that sitting bedside, where we're sitting with them at the bedside. And this is where your hospice team is like your family, because they can talk you through everything that's going on and because if you haven't done that before, and I compare this all the time to birth, giving birth, does not just happen real fast. And it's nothing like it is on the TV. We know that. Someone dying doesn't just happen real fast. It's not often that somebody just dies in their sleep. We usually have that 2 to 3 days of sitting bedside where they look very, very sick. And there may be some sounds that we're not familiar with. And they don't look like people look on TV. And your hospice team talks you through, this is why you're hearing that. This is why you're seeing that. So, and it helps you understand it better. Can I live alone and still receive hospice services? So yes, a person can live alone and still receive hospice services, but they will want you to have a plan and prepare for the time in the illness whenever 24-hour care might be necessary, and that hospice team can help you choose that if you don't have family or friends to help you. Can a hospice patient choose to return to curative treatment? And yes, they can. Receiving hospice care is always a choice. You're not writing anything in concrete. A patient may leave hospice and return to curative treatment. It is their choice. If the patient later chooses to return back to hospice, you can do that too. Can I go back to the hospital and still receive hospice care? This question comes up a lot. Yes. So we're going to talk about something specific. Many symptoms that normally would require hospitalization or an emergency room visit can be successfully managed at home or in a facility by a hospice team. And that keeps us from the stress of hospitalization. And that is why with dementia, so many folks do choose to go on it as early as they can because of the stress of having to go to the hospital with somebody with dementia. So when somebody does go on hospice, typically what the family then says is, we're not doing any more hospital visits. It's too hard on them, it's too hard on us. We're not doing any more hospital visits. But we'll talk about some exceptions. Hospice patients generally only have the need for short hospital stays to stabilize a symptom and then return to their home. So here's an example. Let's say somebody has a really, really severe UTI, urinary tract infection, which is very common with dementia. We're giving them oral antibiotics, they're not getting better. So now we've got to decide, are they not getting better because the oral antibiotics just aren't working? Are they not getting better, dementia, because that part of the brain that's telling those antibiotics to work is no longer working? Then, even if you do an IV antibiotic, is that IV antibiotic going to work? Plus, we've got the trauma of going to the hospital. So sometimes families will say, you know what, we're going to come off of hospice, we're going to go to the hospital, and we're going to do IV antibiotics and just see if that helps. And if it doesn't, then we'll come right back here, go right back on hospice. Or if it does help, because maybe the IV antibiotics helped when the oral didn't. But what they do is they come off of hospice, go do their treatment, and they come right back and go back on hospice. And that's exactly what that's saying. They can go in for a short stay and then come right back onto hospice. So you can go off of it and then go right back on it. Is the decision for hospice care giving up hope or waiting to die? And like I've said several times, hospice is about living. Hospice is about quality of life and comfort for the patient and the family, helping them live fully until the very end of their life, supporting the patient, making them feel better with good pain management and good symptom management. Hospice is an experience of care and support, and it's different from any other type of care. This is very common too. Does hospice do anything to bring death sooner? Because I've had people say, well, I had somebody I knew, they went on hospice and they were dead in 3 days. They killed them. Well, no, they didn't. They didn't kill them. That's against the law. But people do go on hospice and die in 3 days whenever they haven't gone on hospice until they are imminent. And that happens an awful lot, where people don't go on hospice until they are actually actively passing. But they don't do anything to make them pass sooner. The goal is to alleviate suffering and manage symptoms. Hospice does nothing to speed up or slow down the dying process. The role of hospice is to lend support and allow the disease process to unfold as comfortably as possible. Now, I've also had a lot of people say, my loved one went on hospice and they got better. And what happened was you got that added layer of support, and sometimes you will see people, we'll call it kind of a rebound, where they'll rebound and they do appear to be better. Just like sometimes somebody will place their loved one in a facility and they'll say, well, it's like they got better. Well, the disease itself didn't get better. Maybe the environment or the circumstances or everything surrounding it got better, and so they appear to be better. Do I have to be homebound to receive hospice services? We've already talked about that. You do not. Does hospice provide support to the family after the patient dies? A good hospice does. A good hospice has bereavement services that follow the family and the caregivers for a year, for 13 months. And it can be personal visits. It can be grief counseling. It can be sending you cards or something, checking on you throughout the year, on a birthday, on an anniversary, on the anniversary of the death date. But those vary with different hospices as well. Now, here are the terminal illnesses and the most common reasons that people go on hospice. I also just looked these numbers up. So these are new numbers as of August of this year. 37% of the people who are on hospice do have cancer. 18% of the people on hospice are for heart disease. And then look at number 3. 15% of the people that are on hospice, it's because of some type of a dementia. We also know that dementia is now the 5th leading cause of death in people over the age of 65 in the United States. The new Alzheimer's Association statistics have also just come out. They've got a brand new video that's out. It's like a 1.5 minutes long that's on their website that has some of the new statistics that are out that are just staggering at the number of people in the United States with dementia, and it's a terminal disease. So pulmonary disease, 11%, terminal illnesses related to people with stroke or comas, 9%, renal failures, about 2%, and then most all of the rest were made up of these that you can see on the screen. Now you'll see on there one that says adult failure to thrive, and that normally is just somebody at the end of their life. It's a natural death. Their body's just starting to shut down. But we've got to have some type of a term to use for that. So many times you'll hear that called adult failure to thrive. Perfect. I left with plenty of time to have questions. So let me stop sharing and go to the chat. Did anybody have any questions that they'd like to ask, or experiences, or anything that you'd like to add?
I really wasn't aware that they did that many services. I'm gonna look into, once I get the list from you guys, I'm gonna look into that and see what else I can.
They do, and right now some of the stuff is a little bit different just because of the virus. I know that my daughter was doing her internship with hospice this past spring and summer, and was very limited as some of the stuff she could do. So they were getting real creative on how to do some of these legacy type, they call it legacy work, where she was making memory books with people, and she was doing it in a format like this, like through Zoom, where she was doing interviews and writing stories for people. So they'll think outside of the box with you.
Oh, that's awesome. Yeah, I always liked it, having them, because it was another set of eyes on because my wife was in a facility. It was another set of eyes, and plus you get that hour one-on-one, either bathing, it's the same person bathing her, we're a facility, it might be someone different, you know.
Right. Right.
So there is a lot of good points to it.
There is. There's a lot of benefits. I've had people tell me that their hospice team became like their family. When I was working with hospice, I was asked to sit with families at funerals before, because just the time that you're going through with them. Okay, we've got several questions that have come up. Who usually initiates family or medical team? It's both can initiate. Doctors sometimes will go ahead and bring it up. Sometimes the doctor knows the family well enough that they may hesitate, depending on if they know how you're going to react or not react. But families also bring it up, ask the question. And like I said, the worst thing that can happen is that you have an evaluation and they say they don't qualify yet. So, but either can bring it up, the doctor or the family. But you don't want to get into, well, the doctor never said anything, so they must be, well, the doctor may not have said anything just because they didn't say anything, or they didn't think to say anything, or in that 8 minutes they had with you, you know, they were too busy doing all this other and they never brought it up. So go ahead and ask the question, bring it up. Let me back up so I can make sure and hit all these. If a patient goes on and comes off of hospice multiple times, is this an issue for Medicare, like keeps going back to the hospital ER for treatment of heart failure? I don't know that I've ever heard of it being an issue for Medicare. The hospice, though, may really talk to you about, are you ready to do hospice? Because going back and forth to do, because many people, when they're ready to do hospice, will say things like, we just want the disease to run its course. Then that doesn't involve going back and forth to the hospital if you're wanting the disease to run its course, because then we're intervening. So, but yeah, you can go on and off. You can go back and forth. I've never had anybody, I've never heard of it being an issue with Medicare. Is there a list of available not-for-profit hospice agencies? Also, does a hospice worker help with finding an inpatient hospice facility at the end? They can. There is a list of, I don't know that I have a list of just the not-for-profits, but I do have a list of the hospice agencies in the area. Jamie, help me remember, and we'll add that when we send everything out. Alzheimer's Association has a list of, it's divided by county and it covers 40 counties. And I've got that list, so we'll put that on there. Hospice worker will help finding an inpatient facility at the end if that is needed. Absolutely, they will. Let's see. Are there any resources, websites that you can compare hospice companies in the Fort Worth area besides Yelp and Google? Jamie, do you know of any?
Just like with communities, if you go to the Medicare.gov website, you can compare them, but they would, you wouldn't necessarily, it wouldn't be all of them if they don't. I guess they have to take Medicare because it's paid by Medicare. Yep. So you can do Medicare.gov website and be able to compare.
Good idea. So she was saying Medicare.gov. You can go on and you would have to put in the name of the hospice companies and be able to compare them. That's a great place to go. What are some questions to ask when choosing a hospice? Well, let me ask those of you who already have it. Wilson, you may be one. Judy, I know that you, what were some questions that you asked? You could even like have this program in front of you and ask things like, tell me about your bereavement program. Do you have a social worker? It is your chaplain about, I mean, you can ask those type questions, but let me just ask those of you who've used hospice, what are some questions you ask or that you suggest other people ask?
I think a really important question for me was the availability, you know, not necessarily hands-on, because we started with hospice at home, but if I needed to talk to a nurse, you know, would there be someone available to talk to me any time of night or day? And that had to do a lot with Anne being up all night sometimes. And the answer was yes. And then, you know, instruction or counseling about how to use medications, especially for pain and agitation. I remember when they handed me that comfort kit from a community hospice of North Texas, and the nurse actually put it in the refrigerator, and I looked behind me and I thought, I'll never use that. And of course that's not true at all, but it's how you protect yourself. And then I think that I know, frequency of home visits. One of the things that the nurse realized was that I had been doing Ann's medication for many years. And so she said, I'm not taking this away from you. We'll do this together. And which I thought right away was a wonderful response, to bring me into the picture in terms of still being a participant.
That's great. Thank you, Judy.
I found it quite a large, for a better lack of the word, institution, but there was so many people you would get a phone call, I'm so-and-so from, and I'm the chaplain. And then you'd get another one, I'm the so-and-so, and then you'd get another one. So I learned to focus in on learning one person and then when I needed to talk to someone, pick up the phone and say, hey, who was that person that and that's how I didn't try to learn everyone. I just
good. Right. It can be a lot.
Yes.
Yeah, kind of making a relationship with that. Like for so many people, the social worker kind of becomes their go-to, or their chaplain becomes their go-to, or the nurse is their go. But Wilson, I like what you said, where you kind of establish that. And then if I need someone else, you'll help me connect to them. Good. Are some individual memory care centers also hospice agencies, or would that be a separate facility altogether? So the memory care center isn't necessarily a hospice agency. They have hospice who comes in. So like us here, for example, at the West Center, community hospice is housed on our 4th floor, but it is separate from us. They rent that space from us. Now we have people who are on community hospice, just like we have people who are on other hospice also, and their staff comes in here. But you can, when somebody is imminent, they can go to a hospice house. So like when our residents here are passing, they don't move over there to the community hospice house. They stay right where they are in their home, in their bed, in their place here. But let's say if somebody's at the hospital and they have become imminent, they may move them from the hospital over here to the hospice house. So they are separate, but they work together. I guess that's the best way to put that. I am an on-call nurse for Holy Savior Hospice in Fort Worth. This presentation is excellent. I'm very proud. Oh, thank you so much. Thank you very much. We will need, Jamie, you said you need the people who need the CEs to do the chat one more time. It's kind of like signing in and signing out. If we were in person, we'd have you sign in and then sign out, showing that you stayed on the full time. So if you have any other questions, also when we send out this PowerPoint, our phone number and our emails on there. You can always email us that way. And then Jamie, did you want to close with what you need everybody to do?
I think we'll just leave the meeting open for those of you that want to sign out, and we will send the PowerPoint presentation, some of those additional resources that Holly talked about. And then for those of you that need Cs or want to get them, I'll send you an evaluation. When you complete the evaluation, it's online, just to submit, then we'll send you your certificate. I think that's it.
All right, thank you. So if you're needing a CE for social work, if you'll just sign out, just go, just like Pat just did, just put your name and social work, LPC, right beside it, and then you can sign out. But we'll leave it open so you have time to sign out. Thanks, everybody. Thank you, Judy.
They will get a copy of the slides. Is that correct?
Yes, you will get a copy of the slides and you'll get a recording also.
Oh, okay. Thank you.
Hi.
Hi.
I was here, but I kept getting kicked out at the very beginning and I missed the part where we log in. I don't see a place to chat.
Are you on an iPad or computer or phone?
iPhone.
Do you know where it is, Jamie?
You might have to like scroll screens to like, it might be on the same page where you do the, like undo your video. It should be down there. It's a little comment box.
I can tell her where
Okay.
on an iPhone. On the right-hand side is a little series of dots that says more. And if you tap that, the chat option comes up. See if that works. Bottom right-hand corner.
Thank you for sharing that.
And Jennifer, well, I'll make a note that you're for the full time. So if you can, yeah.
Did that work for her, finding the chat on the iPhone?
The doctor approved suggested palliative care right at the beginning of the COVID lockdown, so we have been hesitant about moving forward. We're currently back and forth between Cedar Hill and Houston.
Yeah.
If the doctor brought it up, there's a reason they brought it up. And I would, again, even for palliative care, they've got to qualify. So, I mean, it's adding that additional layer of care. So it might really be something to think about, especially right now, where like Wilson was saying, where he was saying his wife is placed and he likes having that additional set of eyes on her. Surprised no one brought up COVID with hospice care and nursing home. Got it. Thank you so much.
Thank you.
Let's see. Yep, we've got you. Yeah, with the COVID in the nursing home, it has changed how people can go in and out. That's for sure. And not all of the not everybody's allowed to go in and out of every place. It depends on the location, how they're licensed, what regs they fall under. It's different for every place. Still got a few people giving us their name for CEUs. So will you then, Jamie, are you able to just capture everybody from that?
And Deborah, I got your email. Thank you. So I got you signed out.
And I had a chat that came just to me, Julathra Smith. She needed the CEs, but it just came to me.
I think we have everybody that signed in has already signed out through the chat. So
Okay. All right. Thank you, everybody.
thanks.